What was it like to find out you had a tumor on your adrenal gland? Was that worrisome?
I actually felt relieved, to be honest. I searched for an explanation for 4 years, so I felt good.
This is Pituitary Grand Rounds, an interactive educational program developed and produced by Pituitary World News, featuring doctors and patients in conversations about their cases and the fascinating journeys they embark on as they deal with their conditions.
Welcome to Grand Rounds. In this episode, we will focus on disorders of cortisol secretion related to adrenal conditions. Adrenal disorders are an increasingly recognized cause of endogenous hypercortisolism. Interestingly, however, only a small proportion of patients are actually hypercortisolemic. Even fewer have what we call frank or obvious Cushingoid symptoms and signs. Most patients will present with one or more what I like to refer to as gateway diagnoses that ultimately lead to the underlying cause of their condition. This is an oversimplified diagram illustrating the physiology of the hypothalamic pituitary adrenal axis. In this diagram, you can see that CRH, which stands for corticotropin releasing factor, is produced by the hypothalamus, travels to the anterior pituitary gland, and stimulates ACTH production by the gland. ACTH then circulates in the bloodstream and is transmitted to the adrenal gland, where it stimulates the production of cortisol by the adrenal glands. Cortisol then negatively feedbacks on its own secretion by inhibiting ACTH secretion by the pituitary and CRH production by the hypothalamus. This diagram illustrates an adrenocortical adenoma, or a benign adrenal tumor. The same thing happens with adrenal cancer or in hyperplasia of the adrenal glands, but in this case we have an adrenal tumor that's acting as a factory producing cortisol without regard for the body's needs and without control by the hypothalamus and the pituitary gland. The elevated levels of cortisol suppress ACTH and CRH production, so those levels fall. ACTH normally leads to the secretion of all adrenal steroids, and one of the important markers that we can measure is DHEA sulfate. Those levels will fall in the setting of a pure cortisol-producing adenoma. We can measure these hormones. We can look at cortisol levels, ACTH levels, and DHEA sulfate, and often we'll see a pattern here where cortisol levels will be high, ACTH levels will be low, and DHEA sulfate levels will also be low, and that's typical of patients who have adrenal disorders. Next, we'll cover the adrenal causes of hypercortisolism, and we refer to these as ACTH-independent causes because ACTH is not playing a role in the pathophysiology. Again, this is a situation where the adrenal gland is a cortisol factory and produces cortisol, and it suppresses ACTH, so ACTH is not driving the system. The most common cause or most common disorder that we see in patients with ACTH-independent hypercortisolism due to endogenous causes is adrenal adenoma, and these are benign tumors of the adrenal gland. They secrete cortisol autonomously. With the process of negative feedback, they lower ACTH and DHEA sulfate levels. Usually they're one-sided lesions. Most of the time, when they're over 2 centimeters in size, they can cause hypercortisolism. Plenty of these tumors are less than 1 centimeter in size and cause what we call autonomous cortisol secretion, and we can detect those abnormalities in cortisol secretion even though the patient's not hypercortisolemic, because many of these patients will have normal cortisol levels, but they still need to be treated. As you'll see later, these tumors often have an associated morbidity and mortality that's important for individual patients. The next set of disorders are the adrenocortical hyperplasias, and these involve both adrenal glands. As seen on this slide here, the arrows depict both adrenal glands being enlarged. Sometimes these adrenal glands have an appearance of diffuse hyperplasia. Other times it's nodular hyperplasia. Anytime you see more than 3 nodules within an adrenal gland, it's likely that this is the condition. The nodules may be very small or very large. Sometimes they're associated with a number of different inherited conditions like McCune-Albright syndrome or the Carney complex, or even ectopic receptor expression with GIP expression, which can lead to food-dependent Cushing's, or LH receptor expression, where you'd have Cushing's during pregnancy and menopause. These conditions are not uncommon. I see them fairly regularly in my practice of patients who have mild hypercortisolism. And then the last major category of hypercortisolism due to an adrenal tumor is that of adrenocortical carcinoma. These are very large, aggressive, malignant lesions with a poor survival rate. These tumors get to be rather large before you start to see hypercortisolism because they're inefficient producers of cortisol. They're often associated with the production of other hormones by the adrenal gland, including androgens, aldosterone, and a lot of intermediate steroids. So oftentimes patients can have hypertension and the syndrome of apparent mineralocorticoid excess. Anna, thanks for joining us today. I really appreciate the opportunity to have you participate in this Grand Round series with us.
Thank you so much for having me. I'm excited.
And it's nice to meet you. I've been your physician for about a year, and because of the opportunities for telemedicine, this is actually the first time we've met. Right?
Yes, that's right.
So
You do Zoom calls.
it's a very special opportunity to have you here with us today. So tell us when you first learned about your adrenal tumor.
This was like a year ago, and I was having all these symptoms and hormonal imbalances, and so I didn't know what to do. So I went to the OBGYN and I had an ultrasound, and they saw some mass or something that didn't look right. And they just put it on their report like something else. They didn't really pay much attention or anything. And I thought it was interesting. So I wanted to have it checked, like not something, no, you don't have anything, your ovaries, everything is fine. I said, but how about this mass? So I went to my primary doctor, I talked about it with him, and then I think he referred me to an endocrinologist, which I think I was already seeing for my thyroid issues. I have Hashimoto's, but this is that's separate. So they ended up doing an MRI of my abdominal area. And then is when they found this adrenal mass. They actually found two, one bigger one on the right side, I think, and another smaller one on the left side.
And what did they tell you about it at the time? And did they plan anything for you? Did they talk about treatment?
Yes, we discussed about having it probably removed, but there were some other labs that they were not sure, so we just decided to keep investigating if it was the pituitary or if it was the adrenal to confirm.
Okay. What symptoms or problems were you having at the time that may have been related to this mass?
Oh, I have so many, probably most of the ones that were related, and also with my Hashimoto's because they overlap. But I had fatigue. Like in the mornings, I was extremely tired. It was hard to get things done. I had brain fog, really hard to concentrate. I had anxiety. These were probably the most relevant ones.
I saw somewhere in the record that you had gained about 20 pounds, yet your BMI was normal at 24.
Yeah, well, that could be. I was also doing back then bodybuilding, so I was eating a lot to gain muscle, and so I was not sure. I'm not sure if that
So it
was
could have been a
because
gain in muscle weight or lean
yes,
body mass.
which I know I did gain, but because I did a DEXA scan, they analyze your body mass and all that. But yeah, I felt always like water retention and bloated, and my face always changed the shape, like this moon face that they call or something like that.
And you developed stretch marks, I believe. Is that correct?
No, that's the only actually symptom that I didn't have.
That you didn't have?
Yes.
Okay. Hypertension, diabetes?
No.
Okay. How
I
about
had my sugar, blood sugar levels were always really strange. I decided to get one of these continuous glucose monitors on my arm, and then I could see how much it fluctuated. So it would have, at night it would go really low, like I would get alert. And then during the day, if I had a meal that was more heavy in carbs, it would spike like 250. So I always had these fluctuations.
Okay. Did you have any acne or excessive hair growth on your face or
Yes,
parts of your body?
I did. I noticed a difference with my hair growth for sure. But I always thought it was hormonal.
Right. What was it like to find out you had a tumor on your adrenal gland? Was that worrisome, or did they seem to be worried about it? Did you develop any worry because of that, or
I actually felt relieved, to be honest. For
that you finally had a
exactly an
cause,
explanation,
an
yes. I searched for an explanation for 4 years or more, 5 until, well, 4, 5 now maybe, but 4, trying to figure out what was happening with me. And I always thought it was due to Hashimoto's, all these symptoms, but I did everything I could do, changing my diet, doing exercise. So I always said I was the most unhealthy, healthy person. It was really frustrating. So I felt good.
It's fairly typical in medicine. Physicians are usually the guilty parties that if you have one disease, they want to blame everything on that condition and not keep their eyes open for other conditions. And if you practice medicine long enough, you learn that people can have more than one disease process. And many times the symptoms and signs are very much alike for both of those disease processes. And that's what makes it difficult to get to a diagnosis for some people. When you look at most of the symptoms of Cushing syndrome, they're very common in society, and I think that's why the diagnosis is often delayed.
Yeah.
I'm Jorge Fascinetti, Pituitary World News co-founder. Before we continue with Anna's story, I want to take this time to thank you for watching this educational program. As a nonprofit organization, we receive grants and generous contributions from our friends, individual supporters, industry partners, and other organizations who believe in our mission to educate and increase awareness of these complex, devastating conditions. You can receive notifications on the latest news by clicking on our website's Sign Up for the Latest News button and share the articles, podcasts, and videos you see in our publication. We are also deeply grateful for your support. To donate and continue to be a part of our mission, please visit us at pituitaryworldnews.org. Now, let's get back to the program.
One of the important things to keep in mind is that hypercortisolism is a spectrum of disease and complications and clinical symptoms and signs. And this is especially true of adrenal disorders. Some people have mild elevations in cortisol secretion, but aren't yet hypercortisolemic. And on the other end of the spectrum, you can have patients that have marked elevations in cortisol secretion and have a lot of the symptoms and signs as a result of that overproduction of cortisol. And that's seen here, and that this spectrum of conditions is very important. On the left is the first 2 photographs are pictures of Minnie G., who was a patient of Dr. Harvey Cushing's, who he described that we now take as having the classic features of hypercortisolism. It's called Cushing syndrome because of his reports on her appearance. And you can see the enlarged protuberant abdomen, the stria or the stretch marks, the muscle wasting and atrophy in the arms and the legs, and other features that were apparent with her, including the hirsutism. You can't see the plethora of her face very well in these photographs, but these are all the classic Cushingoid features. And then as you move across the images here to a patient who looks simply normal, who had Cushing's due to an adrenal tumor, indicating that you can have this spectrum of disorders and conditions associated with varying levels of cortisol secretion. And this is what makes the diagnosis difficult, and that patients who appear seemingly normal can actually have this condition and still require evaluation and management. At some point, they evaluated you for cortisol excess. So tell me the sequence of events that led to the further testing.
So I started feeling all these symptoms, of having them around when I had the COVID vaccine. Actually, I started feeling worse and worse and worse. And then is when I decided to more actively search for what was happening with me. And I went to numerous doctors. I went to chiropractors. And so I ended up finding this functional doctor that was checking my hormones and everything. And then she noticed that my hormones were really strange, my values. I would go from these values with, really high estrogen, very low, and progesterone, everything was all over the place. And the cortisol always seemed to be consistent, really, really high. So she started to put things together, and she thought that, have you looked into Cushing syndrome? And I said, what is that? I had no idea, never heard about it. So she said, we should check your cortisol. And so she did this specific test. It was like a 24-hour checking you collect the urine over 24 hours. And then she checked other specific values for ACHT or more specific for cortisol. And then she said, I really think you have Cushing. So then it's when I went to the endocrinologist, and then we looked more into detail if that could be.
Did the endocrinologist support that diagnosis, or were they suspicious about whether you had the condition to begin with?
He did. He thought it could be very possible, but he wanted to check himself everything. So we did those tests separately with him to make sure that they were matching, and then he agreed, and then that's when we decided to go that route.
And really, the diagnosis was made after you took the initiative and asked for further study to try to understand
Yes,
what's going on.
that's right. Yeah.
It's very interesting. There was a study done at I think, Harvard Vanguard Groups, something to do with the Harvard Medical Program, I believe, where they looked at the detection of adrenal masses on different imaging studies, and found that if the radiologist suggests that a person undergo further testing for a hormone problem, you could actually improve the rate of doctors doing the testing. But in the absence of that suggestion, most people did not get evaluations for adrenal problems.
That's right.
And I think your story supports that. Whenever an adrenal mass is found, someone should be investigated to see if they have a hormone problem. And there are a number of different hormone disorders that can result from adrenal masses.
Yeah.
But I'm glad you were able to prompt your physicians to consider further testing.
Yeah. No, definitely. I think in the end, it's putting all the pieces together. Sometimes physicians tend to just look at one specific thing that is maybe their field. And it was good to have someone, in this case, the functional doctor. She put all the pieces together, and then she helped me. But it is true that, you have to be your own advocate, right? So I was the one who said, I need to do something because this doesn't look right.
Very good. So let's take a look at Anna's laboratory data. As we can see, she had an ACTH level that was 11. This is considered to be low normal. Early studies back in the 1980s and 90s suggested that ACTH levels less than 20 were often associated with adrenal disease. A lot of physicians this day and age will use levels less than 15 as likely indicative of adrenal disease. However, the fact that the ACTH is still detectable suggests that there is a slight possibility that a pituitary gland tumor could be causing hypercortisolism in a patient like this. Her serum cortisol level was elevated at 23.3. She had a DHA sulfate level that was also elevated, slightly so, and her free testosterone was also elevated. This would raise the possibility that this is truly pituitary disease, but it also suggests the fact that she may have a tumor of the adrenal gland also producing androgens. She had a 1 milligram overnight dexamethasone suppression test, which is the best screening test in this situation, and her cortisol level was 23.5. Normal would have been less than 1.8, so she failed that test, confirming that she has an abnormality in cortisol secretion. I like to refer to that as pathologic cortisol secretion. Her late-night salivary cortisol level was markedly elevated at 0.429, where normal is less than 0.125 at that time of the day. This indicates that she has lost her diurnal variation in cortisol secretion, which is almost pathognomonic and indicative of pathologic cortisol secretion. And then, surprisingly, her urine-free cortisol excretion rate was 250.4, which is 5 times the upper limit of normal, probably 10 times average, indicating fairly significant hypercortisolism. even in the setting of having moderate symptoms and signs and no obvious physical features. There's no way in the world that I would have expected her to have a cortisol level that high based on her clinical appearance. So at some point in the evaluation of your condition, they performed an MRI of the pituitary gland. Can you tell us about that?
Yeah, so once I went to the endocrinologist, he did some tests, as I mentioned, and there were some results that he considered that could be because of a pituitary tumor, not just the adrenal. So then is when I had an MRI for the pituitary gland, and the report, they said they found a mass there. So my endocrinologist was, I think he was not completely sure if it was the case. So then is when he referred me to you for more, to be more, completely sure that maybe that was the case. But I'm glad that he did, because he also referred me to the surgeon or the person who was going to do the test. It's a pretty invasive test where they check which side, like of the pituitary, you could have the blood, and there's a lot of risks associated with it. So I'm glad that I had a second opinion from you.
I'm glad you came to see us too.
Yes.
When I looked at your MRI, I didn't think there was a tumor there, and there's something called bias. So if I order an MRI of the pituitary gland, I'm going to get a report. If I order an MRI of a pituitary gland and tell the radiologist I think there's Cushing's, they will actually see subtle abnormalities and they'll report that as a possible tumor and sort of overdiagnose, if you will, because they've been baited or biased to think that there might really be something there, and they, of course, don't want to miss it. And I think that's what was going on with you. Studies have been done looking at this, I believe there was a study in the 1990s at the NIH that suggested that if you tell a radiologist that there might be a tumor, about 10% of the times they'll say there might be a tumor even though it's normal. If you have 3 different radiologists looking at it, not knowing there's a tumor, it'll be maybe 1 or 2%. They might think there's a tumor there. So it's a real problem.
Yeah.
Physicians can be biased if they think they're looking for something. The pattern of your laboratory testing suggested to me adrenal disease was the most likely cause, and certainly you wouldn't need that petrosal sinus sampling test, which can be very dangerous. It's very useful, but it also is not without complications.
Yeah.
So I'm glad you came to us so we could get on the right track and get your adrenal disease taken care of.
Yeah, me too.
This is a representative image of Anna's abdominal CT scan. The black arrow here is pointing to the right adrenal tumor that is somewhat ovoid in shape. The left adrenal gland was normal to my review. There was a suspicion that she might have also had a left adrenal tumor, but it really wasn't that obvious to me. But clearly this lesion is fairly straightforward and indicative of an adrenal tumor. Adrenal lesions are very commonly detected on CT imaging studies of the body. It's said that the older you are, the more likely you will have an adrenal lesion, and they've been seen in up to 3 to 10% of elderly patients who have had CTs for one reason or another. This is the same for other endocrine glands as well. For example, a similar proportion of elderly women will have thyroid nodular disease. Pituitary tumors have been found in 20% of patients who undergo autopsy after death. It's important, regardless of the endocrine gland, but especially with adrenal disease, to evaluate those patients to see whether these tumors are producing any hormones in excess. The dexamethasone suppression test is a good test to assess for autonomous cortisol secretion in patients with hypercortisolism or abnormal cortisol secretion, regardless of the type. In the setting of adrenal adenomas, it's been reviewed by several investigators. The old cutoff for the DST used to be a cortisol level less than 5 was considered to be normal. Anything over 5 was considered to be abnormal. More stringent criteria are applied in this day and age where anything under 1.8 is considered to be normal, anything over 1.8 is considered to be potentially abnormal, and anything between 1.8 and 5 is considered to be circumspect and certainly needs to be evaluated further. But if you take a look at those patients who have DST results greater than 1.8, you can see by the data presented here that almost 50% of patients will have with adrenal adenomas will have an abnormal DST. If you look at the Petrova study, for example, 9% of patients had a frankly abnormal test with a cortisol greater than 5, and 35% had a DST that was between 1.8 and 5.0. That's a combined total of 44% of patients of 365 had abnormal tests suggesting they had abnormalities in cortisol secretion, which some would equate to mild autonomous cortisol secretion if the patient didn't have hypercortisolism. Others would say had frank hypercortisolism if those urine cortisol levels were frankly elevated. The reason it's important to evaluate patients who have adrenal tumors or hyperplasia is that the abnormal cortisol secretion can have important consequences that affect the life of the patient. In this analysis of data from 32 studies looking at the outcomes of 4,121 patients with abnormal cortisol secretion due to cortisol-producing adenomas versus those with non-functioning adrenal adenomas after 12 months of follow-up, they found that those who had evidence of abnormal cortisol secretion or hypercortisolism were more likely than those with non-functioning adenomas of the adrenal gland to gain weight during follow-up, have type 2 diabetes mellitus at baseline or a worsening of diabetes mellitus during a period of follow-up, have worsening or new cardiovascular risk factors, and experience new cardiovascular events. So how did you feel when we told you that we thought you had adrenal Cushing's and that your tumor needed to be removed surgically?
Well, I felt relieved that it wasn't the pituitary because I was a little scared of that surgery and even the test. And then I felt good about, that this is going to be it. And, it's going to be the end of at least most of the symptoms.
So I referred you to our endocrine surgeon who takes the adrenal tumors out.
Yes.
And you went through that process. Could you explain to us what that was like?
That was another story that I am very happy how it ended, by the way. We didn't discuss this, but I remember you originally referred me to one of your surgeons that you work with, and the wait was very long, and then I was, really, I wanted to have it done before the end of the year. And then I thought, maybe I can find a surgeon here in San Diego. It makes sense, right? We have a lot of good hospitals. So I discussed that to you, I think, with you. And then you said, yeah, it's fine. So I found a surgeon at Scripps. And then it was a bariatric surgeon where they do laparoscopically. And I didn't know anything about these or surgeries. I didn't do my research or anything. So I thought laparoscopically was now the last trend and what it was the best. And somehow, I don't know why, I kept reading, and I came across this new technique that it was from the back for the surgery for adrenalectomy. And it was less invasive, less time, and it totally made sense to me. Why would you go from the front and having to move all the organs and all these possible complications when you can do it from the back? It made total sense to me. And I started doing my research and looking for the best surgeons for this type of procedure. And then I found that the doctor, one of the surgeons that you recommended, was actually one of the leaders that was performing this type of surgery. So I got super excited. And even though I already had the appointment with the other surgeon, I had even done the pre-op tests and everything. I just said, I'm sorry, I want to really do this the other way. I had a good feeling. And then it's when I contacted her, and she was wonderful. She found me, a day for the surgery, like right away. I explained my situation, and I had the best experience, actually, with the surgery.
How long were you in the hospital?
Oh, just one night.
One night. Yeah. Truly amazing. The old way of doing adrenal surgery was usually a 7 to 10 day hospital stay with marked pain and discomfort. So this new procedure is really tremendous to be able to offer that to patients.
Incredible. I had the surgery, I think it was on Friday, and then Saturday I slept because I was with the medicine, which I didn't think even need pain medication, honestly. And then on Sunday, I was walking around, even Saturday afternoon, I was walking around San Francisco with my friend. Sunday, I went to dinner. I'm like, am I supposed to eat normal food? But I felt great. So, and the scars were minimal. So
That's tremendous.
it's incredible.
Minimal pain.
Oh, no, yes, nothing. I do exercise, so I just try to limit, of course, exercise, but it was just maybe a little pull in the skin. It just, yeah.
I think it's one of the advantages of coming here for surgery is you get to turn in a little bit of a mini vacation, so to
Yeah.
speak. We have patients who have surgery for pituitary disease, and they're walking around in Marin headlands, probably 3 to 4 days later before they get on a plane on a Saturday morning after surgery on a Tuesday. So
Yeah, I actually flew back. I talked to the surgeon and she said, if you're fine, and I think I went back to San Diego on Monday.
that's great.
And everything was fine. I had no pain. I couldn't believe it, honestly.
So I was delighted to see that your pathology showed a benign tumor. I was actually concerned that it might be malignant given its size and the fact that when the surgeon took it out, it was bigger than it was when it was detected on the CT and the MRI. It was 3.6 centimeters in size. You had an elevated DHA sulfate level, which usually you see a low DHA sulfate with adrenal tumors that produce cortisol, but that made me think you might have a malignant lesion. I was just ecstatic to see that your tumor was benign. The other thing that was really good, and it sort of speaks to the fact that this was adrenal disease all along and not pituitary, which was potentially suspected, was that your ACTH levels stayed low and your cortisol levels were low after surgery. And that's really the proof that this was an adrenal tumor all along. And so thus you had what we call secondary or central adrenal insufficiency. This is a complex situation where the cortisol turns off the hypothalamus and the rest of the pituitary, so the other adrenal gland wasn't getting any stimulation at all. It was suppressed, and it takes a while for that to wake up. So as you recall, I gave you hydrocortisone treatment to replace your adrenal function. And how did you do on treatment there for a while?
I had a little side effects from the medication, but it helped me to feel a little better. I took it for 4 months and I went up gradually. So I think it was good because it did what it was supposed to do in the end, but I'm happy that I didn't have to be on it for more than 4 months.
Yes, as I recall, we stopped your levels when we proved your other adrenal gland had
Yes.
awakened. And in my experience, usually it's 4 to 6 months that someone who has one adrenal removed will require steroid supplementation. And I think that your course was about right on target there for 4 months, as I recall.
Yeah.
So now that you've been off steroids for probably 6 months or so, I can't remember exactly, how do you feel relative to how you felt beforehand? What's better? What's not changed that might be due to the Hashimoto's?
That's right. So it's been slow process. I remember last time we met, I asked you, I don't feel a lot better. Why is it? You said you have to be patient because honestly, I remember you said less than 6 months is rare, right? You said I could start feeling better between 6 months or even up to a year. So I really didn't feel a big difference. Mostly it's the fatigue. This is what I felt like I wanted that to be gone. I think this past couple of months, I've seen a little more improvement, but I don't feel like I'm back where I was before. But again, the Hashimoto's probably has a lot to do, and I feel I have had a flare-up after that, because I know the symptoms that are associated with Hashimoto's, and I know it's nothing to do with the adrenal problem. One thing that it was the biggest problem for me after the adrenalectomy was my mood. The mental part was the hardest. I had really bad depression and anxiety, so that was the worst, I would say. And that hasn't improved. So that's the hardest thing I think I've had to deal with.
So as a personal trainer, exercise physiology. You understand physiology of exercise in the human body. How do you feel that your physical capabilities are and your ability to train have been since the surgery? Do you feel like you've improved there? Was there a setback after the surgery? Is anything different?
Definitely a setback. But again, not so much for the physical part, but more for the mental part. Because actually, I noticed, and I think that's a positive thing, before the surgery, I felt like there was no matter how much I trained, I wouldn't build muscle. I wouldn't recover properly. And I definitely noticed that. And I did everything. I took my supplements, glutamine, proper rest, stretching. I always was very regimented for all that. So I've noticed a little change for that. I feel like even though I don't exercise as much as I used to or do the weightlifting, I don't do it as much, but I can see my body recovers better. That's the positive part. But the mental part is the one that has been the hardest. So I haven't been able to go back to my routine because of that.
You mentioned beforehand that you had brain fog before the diagnosis. Is that any better since the surgery?
No.
That could be other
Yes.
potential causes
Yeah.
there. So, how about your mental function? Has that changed at all?
I think the fact that I have brain fog, it's always a limitation.
Okay.
My vision also is something that hasn't improved. I've been to the eye doctor many times. They say everything is fine. I don't see anything. They have checked my optic nerve, any other possible issues, my peripheral vision, and everything seems fine. And that was also one of the biggest problems that I had. I don't know if it's the brain fog or I always see black blurry. And that hasn't improved either. But again, I have Hashimoto's, so I don't know what comes with what, or the hormonal part makes your eyes dry, and everything is connected. So it's so hard to say what is coming from the adrenal issue or the recovery or Hashimoto's.
You know, it's interesting. You're a pharmaceutical chemist, medicinal chemist, or organic chemist,
Organic
whatever you
chemist,
like to say. So it's interesting. The patients that I have that are high functioning and very intelligent often are the most sensitive to the little bits of brain fog. I think regular people who don't have high intellect, because not all of us, you're smarter than me, not all of us have high intellect, and some of us wouldn't recognize it as much. But I have another patient who you remind me of, who, when you talk with him, you would think he's very highly intellectually functioning, but he can't do his work as well as he would like to do because of his brain fog.
It's so interesting because that was my first red flag 6 years ago, even before any other symptoms. I remember talking to the doctor and say, I can't think the same way as before. I have brain fog. I would say that was the first. Yeah.
And I told him, as I tell everybody with Cushing's, that the unfortunate thing is that cortisol levels, when they're high, kill cells that form memory. The hippocampus part of the brain seems to be important in forming memories, and you can see in patients with Cushing's, the hippocampus is actually smaller in size than in normal people without high cortisol levels. Normal people are age matched and size matched and all of that. So, and it seems like those changes are irreversible. Yeah, I think your story is similar to many, is that you'll have a little bit of improvement, but it never really sort of goes away or recovers fully. And that's really an effect of the steroids that you've taken, not that you've taken, that your body has taken its toll on you because of that. So that probably is not going to fully recover. Could be related to your thyroid, but it's probably related to the chronic excess steroids that you'd had.
Yeah, I was really high, as you probably saw.
Yes.
If the maximum was 50, I was in the 250 range.
Right.
And I was like that for many years.
You had enough steroid, probably. You were 5 times the upper limit of normal, which is, if you figure the average is probably half of the upper limit of normal, you had enough steroid for 10 people. That's going to affect your brain in permanent ways. So I wish that would get better, but it's not something that I can do anything about.
Yeah. I'm just trying to do everything I know or I can to make the symptoms better, but more thinking about the Hashimoto's, because I think it contributes a little bit to all this.
It's never a good consolation, but I tell patients often that imagine how much worse that it would have been had you not been diagnosed when you were and treated, because things could be a lot worse for your future had you not decided to seek out what's really going on with my adrenal. Why do I have a tumor there that shouldn't be there?
I actually think that this tumor is what triggered my Hashimoto's. Honestly,
That will
I've been
happen.
reading. Yeah.
Yes, as high steroids
Happens.
will suppress Hashimoto's. You could take anybody with Hashimoto's and treat them with high doses of steroids, but it's the side effects of the steroids that limit that as a viable treatment opportunity. And we usually just let Hashimoto's burn itself out and replace with thyroid hormone. But that doesn't mean these patients are free of symptoms and signs during the period that their Hashimoto's is active. And we'll often see, well, not often, but occasionally you'll see if you take care of enough Cushing's patients, people will have a flare of autoimmune diseases once their cortisol levels come down to normal after you've treated the Cushing's.
That's great that you mentioned that, because I forgot. One thing that was interesting to me is after the surgery, I checked recently my hormone levels, and then they checked my antibodies, the TPO antibodies. I was surprised to see they went up, like quite a bit. So during COVID, on the worst of my symptoms, they went up to 1,000, in the 1,000 level. And then I was able to lower them to 300 before the surgery. And then the other day when we checked, not long ago, it was around the 600 range again. So I was surprised,
Yeah, it's unfortunate that that happens. I've seen people develop rheumatoid arthritis, lupus, other autoimmune conditions after successful treatment of Cushing's, and it's sort of regrettable that you treated their Cushing's, but you have to do that, and it's the rare patient who'll have these problems. But I've seen it enough to where I don't think of it as rare. It's always in the back of my mind that if someone has a, joint aches and complaints or a rash or something like that after treatment for Cushing's, that they need to be evaluated for an autoimmune condition.
we just learned to live with it.
That's the only thing we can do.
Yeah, it's really
Live
frustrating.
with what we have, right?
Yes.
When it comes to general screening of patients for hypercortisolism, if you will, suspicions should be high in certain patients. A number of different practice guidelines have been published, and they suggest screening for hypercortisolism in certain patient populations. And those are patients who have unusual features for age, such as a young man with osteoporosis, for example. Patients with clinical features of classically described overt Cushing syndrome certainly should be evaluated. Patients with pituitary adenomas and clinical features of Cushing syndrome, and I would argue that not necessarily needing to have the clinical features, should be screened for hypercortisolism. And then all patients with adrenal incidentalomas or tumors found on CT scanning for other reasons should certainly be evaluated to see if they have abnormal cortisol secretion. It's clear that the clinical suspicion of hypercortisolism should be very high in patients who have resistant hypertension, especially those with uncontrolled blood pressure even while on 3 or more drugs, including a diuretic. Those that have decreased bone mineral density or unexpected fragility fractures, and especially those who have normal gonadal function or present at a very young age with osteoporosis. Patients with uncontrolled type 2 diabetes mellitus, and especially those who are on multiple therapies or requiring high doses of insulin. And patients with tumors such as tumors of the pituitary gland or adrenal gland. Screening for hypercortisolism is fairly straightforward, but the interpretation of test results is not always so. The best test to screen patients who are thought to have an adrenal tumor, or maybe a patient has a CT scan that shows an adrenal tumor, the first test should be chosen would be a 1 milligram overnight dexamethasone suppression test. In this test, we give dexamethasone 1 milligram at 11 p.m. and we check cortisol levels at 8 o'clock the next morning. A normal result is less than 1.8 microgram per deciliter. This test is evaluating the ability to suppress cortisol production. So in patients with adrenal tumors or hyperplasia who have a cortisol factory, ACTH levels are already low, and when we give dexamethasone, we're not going to lower those any further. So it's a really good test to screen for adrenal disease. Another test is the late-night salivary cortisol level. This is a test performed by checking a cortisol level on saliva obtained when levels should usually be at their lowest, essentially prior to bedtime in a patient that has a normal sleep-wake cycle. It's important to sort of get that cortisol at the patient's 11 p.m., if you will. So if a patient does shift work, you have to adjust that timing of obtaining the sample to their bedtime, not simply tell them to collect at 11 p.m. or midnight. What this test is looking for is the loss over the diurnal variation in cortisol secretion, which is a very early finding or abnormality in patients who have cortisol hypersecretion or abnormal cortisol secretion, regardless of whether the cortisol levels are even high. So I think it's pretty much the best test in my mind to check for patients with pituitary disease. You'll often see it abnormal in some patients with adrenal disease. What's more important, however, is some people with adrenal disease will lose their diurnal variation, but they'll still have normal levels at nighttime. So you could actually miss a patient with adrenal disease if you just checked the late night salivary cortisol and didn't do the DST. And the urine-free cortisol excretion rate can be very useful, but it's important to remember that many times patients with adrenal disease have normal 24-hour urine cortisol excretion rates. However, they may have mild to moderate symptoms or hypertension or diabetes and a higher risk of cardiovascular mortality. The important thing here is to recognize that those patients will have symptoms and signs even though their cortisol level is normal, because it's probably too normal for their physiology. For example, if the normal range is between 5 and 45 and someone's set point for cortisol secretion is at 15, and that's normal for them, and maybe their body range is 12 to 20, but their cortisol level would be maybe 40 with an adrenal tumor, that's still in the normal range, but could be double what they should have normally. So that's why these patients sometimes develop symptoms and signs, even in the setting of a normal cortisol level. It's very important to keep in mind that if you take shortcuts in the evaluation of patients with suspected hypercortisolism, you can make errors in both diagnosis and treatment. Therefore, you should proceed in a stepwise fashion. It's all about building a clinical suspicion up front and identify something about the patient that causes you to want to further evaluate them. It may be the premature osteoporosis or the drug-resistant hypertension or diabetes or other derangements that lead to that clinical suspicion. Or perhaps the patient was found to have an adrenal tumor or pituitary tumor. At this stage, it's important to exclude exogenous hypercortisolism due to steroids in one form or another that the patient may have taken that could be masquerading as hypercortisolism. Once you have that adequate clinical suspicion, you can start with a biochemical investigation and do some diagnostic tests that can also function as screening tests, but to evaluate to see whether there's abnormal cortisol secretion with the DST or the late night salivary cortisol or the urine cortisol. You may repeat these studies a number of times, do all three, or just select one or two of your favorite studies. At any rate, the goal is to arrive at a conclusive evaluation that suggests the patient either has hypercortisolism or they don't. And only then can you proceed with a differential diagnosis test in those who you've confirmed have abnormal cortisol secretion. We start with the evaluation of the early morning ACTH level. If it's low, it suggests adrenal disease, as we saw with Anna. If it's normal or high, it suggests an ACTH-dependent source, either pituitary or ectopic ACTH secretion. And depending on where the ACTH is, you then decide on imaging studies. So patients with high ACTH levels, they don't require adrenal CTs, whereas if the ACTH level is low, you would want to do a CT. Patients with low ACTH levels don't need pituitary studies. Patients who have low ACTH levels don't require inferior petrosal sinus sampling. It's not a diagnostic test for hypercortisolism. It's a test to differentiate whether a patient has a pituitary tumor or ectopic ACTH hypersecretion once you've proved they have ACTH-dependent abnormal cortisol secretion. Again, make sure that you proceed in a logical stepwise fashion so that you don't make mistakes and do studies that the patient doesn't require or studies that may actually harm the patient if they have an adverse complication of that particular study. So it's been a wonderful discussion. Do you have anything else that you would like to add about your experience or your workup or Cushing's in general?
Well, in my case, I just would say that is very important to, in the end, advocate for yourself, and with the help of the doctors. But in the end, I realized I became my own doctor, and listening to your body, looking at things that don't seem right, and putting all the pieces together. That was important for me, and always do your own research against the same thing and find the best doctor, the best approach, the best that you think is going to be for you, and that's important. And also I realized there's not much information about Cushing's, or at least I couldn't find much, and I never heard of it. And so it's just a little confusing too, if what is the pituitary or if it's the adrenal glands. So you helped me quite a bit to understand how this works, and I know you are doing a lot of work to make it easier for people to understand and for patients to understand what's happening, what are the symptoms, what should I look for. That's very important. So I think it's great what you are doing.
Well, your story is very interesting to me. It highlights adrenal diseases and the fact that some people with Cushing's actually have an adrenal gland problem, and that it's not often that patients who have high cortisol levels are going to look like the classic patient with hypercortisolism that I've talked about in the earlier part of this Grand Rounds presentation today. And I think you exemplify that. You had some symptoms and signs, but you didn't have the textbook picture of Cushing's. And had you not really worked to sort of push forward to get a diagnosis or understand what was going on, I'm not sure that you would have been diagnosed for a couple of years. You might have had even a 5 or 10 year delay and suffered greatly as a result of that. I think coming to see us at UCSF was a good thing, and I think it highlights that you should occasionally be willing to travel for healthcare.
Yes, definitely.
Try to get a specialized surgical procedure like you had, or even a diagnosis, for example. And I'm glad you were able to make it up to see us for that.
No, I'm very glad too. It was a great experience in general. The hospital, the doctors, everything has been fantastic. The surgeon.
And I really appreciate you participating today, because you're using your experience to help teach others about the condition and to give them the courage to, and the empowerment, if you will, to be able to advocate for themselves.
Definitely, yeah. No, I was very happy that you gave me the opportunity, to explain and to, talk about my experience and help if I can help other people. And I love that this setup where it's easier to discuss, not just go to a book or something that is more technical. And I understand it's hard for some people, right, to follow or to see yourself. This is more personal, and it's easier for people, I think, to understand and see yourself in the situation. So
this is another important part of our mission at Pituitary World News, to be able to distill information and present it in a way that patients can understand it, and in a way hopefully the healthcare providers can understand and incorporate it in their practices. So thank you very much for participating.
Thank you so much.
Tremendous.
Thank you.
So in summary, Anna had hypercortisolism related to a functioning cortisol-producing adrenal adenoma. Most patients with this condition will not have overt features of Cushing syndrome, and that certainly was the case here, despite the fact that her urine cortisol excretion rate was markedly elevated. Many patients will have what we refer to as hidden hypercortisolism and present with one of the gateway diagnoses, such as hypertension or diabetes mellitus. It's important to evaluate all patients with adrenal adenomas for the possibility of cortisol or even aldosterone overproduction, because many of these patients have secondary conditions that can result in significant morbidity and mortality. Thanks for watching this episode, and stay tuned for future episodes of our Grand Round series. Have a great day.